the lumbar directional preference exam is critical to master, as it is the centerpiece of your entire lumbar examination. It defines a condition called a lumbar derangement, which, when present, is the most rapid and significant change we can make within the lumbar spine. When we talk about these different lumbar classifications and these different types of lumbar conditions that might be matched with different interventions of manual therapy or exercise, directional preference really is going to be the most profound change you're going to be able to make within your patient. The research on directional preference is also significant, showing that if a patient exhibits directional preference, their prognosis is excellent, their ability to self-manage the condition long-term is good. It's something that we really just can't afford to miss. So we want to make sure we spend ample time discussing how to do the lumbar directional preference exam and becoming very proficient at it. So the first thing is just to really define what is directional preference, and I'll show you a graphic here in a minute that will help you understand what this is. But basically, it is a movement of the lumbar spine that, when performed repeatedly to end range, will produce a rapid, significant, and lasting improvement to relevant baselines. That's important to memorize. So what does that tell us? Well, again, like I said previously, it tells us about a particular classification within the lumbar spine called a lumbar derangement. So we'll go over how this works, how to create the exam to make that clear. And another way to term a repeated end range movement in other schools of thought would be a physiologic mobilization. That's, just basically you performing repeated, just the patient's doing active range of motion, dynamic range of motion. But yes, it uses repeated movements to end range. And it can be static. It doesn't have to be repetitious movement. It could be holding a particular position at or near end range. The other reason that this is so important is the self-efficacy piece. What we learn from lumbar conditions in general, we know how common they are, but we also know how recurrent they are. So it's common that a patient will recover from a particular episode of a lower back or sciatic type problem, but the odds that they're going to have that emerge again at some point in the future is high. And so a patient that is able to exhibit directional preference and they're able to learn the exercise that resolves the problem, they didn't require, or they may not have required, I should say, manual therapy. Anytime the patient is able to use their own movement to resolve the condition, and it's simple. It's not a list of 5 to 10 exercises. It's 1 or 2 things that will make a profound difference. So it's easy for the patient to memorize. It's easy for the patient to perform. And they can understand that if the condition starts to return, they're able to return back to that directional preference movement to start self-managing again. So here is a good analogy that might help make directional preference a little bit more clear in terms of what's going on in the lumbar spine. So we call this the nail and board analogy. So if this represents a board and you have a nail sticking out of the board, well, there's 3 distinct things that have to occur if the nail is going to be repositioned back into the board. So the first thing is the direction. You have to be able to hit the nail on the head in the right direction to start moving the nail back in position. If your hammer is striking at this direction, this isn't going to work very well. The second thing that needs to happen is force. So if you are tapping the head of the nail and you're just barely tapping the head of the nail, well, you've accomplished the direction. You're trying to do the right thing. but you are not using enough force, so the nail doesn't move. So you have to strike the nail hard enough to get it to move. The final thing is repetition. Once you hit the nail once and it moves a little bit, you continue. Now, if that continues to go fine, the right direction with the right force and the right reps, eventually the board will reposition itself all the way back where it belongs. If the nail were to stop moving, it goes part way, gets to here, and you keep hitting the nail and the nail's not going all the way back in the board, well, then we just need to cycle back to force and increase the force. You hit the nail just a little harder and you finish the job. So within the lumbar spine, I think there's a couple of theoretical models about what is actually happening in the lumbar spine when we see this phenomenon occur. But you can imagine that if this represented a mechanical change that occurs within the lumbar spine, this is going to be rapid. It doesn't take a long time for this to occur. I don't need to hammer the nail for weeks and weeks. You're going to notice rapid improvement as soon as you start doing these three things correctly. So it's rapid. It's significant. Significant meaning you don't have to guess, well, oh gosh, maybe it's a little better. I don't know. It's going to be unmistakable. Yes, it's better. The patient's going to be able to articulate, well, this feels better, or yeah, I'm moving better. Some relevant baseline will clearly be better. And then the third piece is that it needs to be lasting. So there can't just be a 5 or 10 minute improvement and then it goes right back to where it was. We'll talk more about that in another section of this course, but it needs to be a lasting change for this to be confirmed. So a couple theoretical models about what is happening in the lumbar spine. The first explanation or theoretical model is the disc model. This is also an exceptional way for a clinician to think about the concept. But what we can't do is make an assumption that if a patient exhibits directional preference, that they have a disc problem. We can't do that. There's no way to prove that. But it is a very good theoretical model, and I'm sure that in many cases that this is probably accurate. So if we take a disc, this is an eagle's eye view, and inside we kind of have we got the nucleus in here. Let's take annular fibers. Surrounding the disc like so. We have the spinal cord. We've got a nerve root exiting here and a nerve root exiting here. So when somebody has a bulging disc to some degree, that is essentially a disruption. So here's a great definition for a lumbar derangement. So if somebody exhibits directional preference, we can classify that as a lumbar derangement. And that would be an alteration, a disruption within the normal resting articulation of a joint. So this is an inner body joint. That's what the disc is. So it is a disruption in the normal resting position or the normal mechanics of a joint. Something's off. If you're driving a car and the wheels are out of alignment, there's a derangement of your wheels, and now it is moving the way that it is not supposed to move. So if this disc material starts to bulge, maybe it's disrupted some of these annular fibers, and now you've got a derangement of this material. Well, if you want to take that nail and board analogy, we can use a movement that would apply a force in this direction. We could use a movement that would apply a force in this direction. We can use a movement that applies a force in that direction, etc. We can move one in this direction. So a movement, like if the patient is bending forward in a lumbar flexion, they're going to compress the anterior portion of the disc, and that would theoretically start applying a force this direction and might push material in that direction. If you extend the lumbar spine, theoretically it could start pushing the opposite direction, this way. If I was to side bend to the right, that will compress the right side and apply a force in this direction. Then there's movements where you can combine extension with a side bent, side glided position that will apply a force at more of an angle. So as we do this, we apply a force in a particular direction, and then we reevaluate the response. So this is one theoretical model that can at least help the clinician to frame their mind about what they're doing. Just like the nail on the board, if I had a patient do a set of extension, so this motion here, this direction of force, and I say do 10 repetitions of that movement, and there's some improvement, well, then I could say, all right, well, let's do some more. I could either pick, let's do more reps, or I could say, let's add force. Let's progress the exercise. You could do either one or both of those things and then reassess again as if you're trying to think about pushing this material in that direction. Now, I can't emphasize enough that this is not, you cannot assume that this is what's happening if somebody exhibits directional preference. One of the things that's common is a temporary significant improvement. We'll talk about this later on in another part of this course, but you might encounter a neurophysiologic response. A neurophysiologic response is a non-mechanical change. The structures of the spine haven't changed, but you have induced a mobilizing effect within the nervous system, almost like a baby that's fussy, and you just gently shake the baby back and forth to soothe the nervous system. Sometimes a repeated mobilization of a joint can create that same effect. The difference, though, is that change is probably not lasting. That's why it is so important that you remember that this needs to be rapid, significant, and lasting in order to call it mechanical, a mechanical problem. So just again, to frame your mind around, kind of way to wrap your head around what's happening inside the lumbar spine is just a good way to think about it. So with respect to how this system works, this is a important graph or table to memorize. So step one is you need to determine what your baselines are. You got to get at least two. So your primary baselines are going to be here. So just if the patient is sitting there, you could ask them, how are you feeling? And they might say, well, I've got some ache or some pain in my back and radiating down into the buttock. And you might say, okay, is there anything else going down your leg, any numbness or tingling, anything at all as you sit here? So really capture exactly what the patient is feeling in that moment. And that's a great baseline. Active range of motion. When you've gone through that exam, you're going to look at the quality, the quantity, and the symptom response of active range of motion and note that. And then pick some functional movement. It could be anything from, having them squat, or it could be having them walk around the clinic. It could be really anything. Bending over to pick something up. It doesn't matter. Whatever it is, whatever's relevant to the patient, you could capture that. Secondary baselines are down here. You could use any one of those things. They're not as quick and good to use as those primary baselines, but regardless, get good baselines. And then the second step right here is where you need to pick your direction. So like I said here, we need to pick, either flexion, extension, a side type movement, a side glide is more common. and then maybe a combined motion. So you have to pick your movement. Now, here's an important thing. You want to start sagittal. You start in the sagittal plane. That is the movement of the lumbar spine that those facets are most designed to do. It's the motion in the spine that has the greatest quantity of motion. Rotation has very little movement at each vertebrae. So you exhaust the sagittal plane. There's one exception to that. If a patient comes in really standing crooked, what's called a lateral shift deformity, you would start in the frontal plane. But other than that, you start in the sagittal plane. So you're going to either pick flexion or extension to start. So you pick your movement that you're going to start with, and that can be dictated based on the history. If somebody were to say that their symptoms start going down their leg after they've been sitting for a while and it feels better when they get up and walk, you're probably going to pick extension first. So the history can guide what you're going to start with. Then the second thing is going to pick, are you going to be in weight bearing or non-weight bearing? Weight bearing just means if I'm going to pick extension, is the patient going to stand up and just, put their hands on their back and extend, or are they going to lay down and do a press up? So are they against gravity or are they not against gravity? And I'll tell you right now, if somebody does this motion here in standing and it kind of aggravates their symptoms, don't immediately move on. Check the unloaded. Check the unloaded. That is important. Because sometimes patients will respond very well when they're laying down and not well when they're standing up, just because you've changed the load. So once you decide that, then you are going to perform at least 10 reps, unless the patient was really having a hard time with that and getting worse. But you'd want to do 10 repetitions. And, you need to, pick the amount of force. Now, the amount of force you're going to use is really always going to be patient generated first. There's no sense in you putting your hands on the patient and being aggressive or anything like that. Just have the patient do it under their own power for 10 reps, and then you simply check the response. So these things are in order. So once you check the response, well, while they're doing the movement's either going to increase or decrease symptoms. It'll either abolish or produce symptoms. Produce meaning they didn't have any symptoms to start. They were symptom-free when you started and you brought something on. Increase means you started the exam with symptoms, they just got worse. And then there might be no effect. That's an option. Then after the fact, they might feel better. Like if they said, it feels good while I'm doing this. Oh, good, it's decreasing. But then after, it's no better. It doesn't last. Or they might say, symptoms are kind of increasing as I do this, but then when they get done, they're not any worse. Or maybe they are worse. And it's not just symptoms. You're going back to your baselines. That's the key here. Go back to your baselines and make a decision. Now that we did this motion, are you better? Are you worse? Are you no better, no worse? And that's going to tell you what to do next. Obviously, if somebody says, I feel better, their baselines look better, well, then you're going to do another set. See if it gets even better once you do a second set. If they are no worse, then you're going to explore further. So this is this idea of, green, yellow, and red light. These are the symptom responses of a yellow light right here. You produce or increase symptoms, but when you're done, it's not any worse. So you don't need to freak out and stop. You can explore that further with either more reps or add a little more force or whatever. But you're really wanting to get one of these two responses, because a red light will tell you that you're affecting the problem, but it's probably the wrong movement. You need to make some change. So it helps you to make a decision quickly about, I got to make a change. Green light's even better, of course, because then you're going to start transitioning right into treatment now and thinking about you've diagnosed them properly now with a lumbar derangement. So you need to assess those baselines, decide if it's a red, yellow, or a green light, and then you make some changes. So let's say the patient is worse. What are you going to do? Well, you're going to go backwards now. When you started the process, you went in this direction. If a patient feels worse, you are going to reverse. You're going to say, well, did I have them do it too aggressively? Do I need to back off the force a little bit and maybe not have them push as hard into the motion? Or maybe you need to change the load. If you were doing standing lumbar extension, maybe you need to have them lay down and do a press up. If that didn't work and you've made those changes and the patient is still at a red light down here, you probably then need to change the direction of movement. So if you were doing extension, maybe now you need to assess repeated flexion and see if it has the opposite effect. It's opposite biomechanically, so maybe it will have an opposite or an opposite symptomatic effect. So you would change the direction. And then once you change the direction, what are you going to do? Well, you're going to reassess your baselines again and make a decision. Was that green, yellow, or red? So the process essentially is cyclical. You start going in this direction and then you cycle back. And it just keeps doing that back and forth until you figure out, I've got the right direction, the right load, the right amount of force. And then where you rule this classification out, where you say this is not a lumbar derangement, there's no directional preference, is where you've worked the system. You have assessed the sagittal plane, frontal plane, maybe the transverse or combined planes. You've gone through these different movements, and the patient is not exhibiting a directional preference. Then you need to start looking at your other classifications, your other 6 classifications, and saying, okay, what other clues do I have that might help me to link a patient to one of these other diagnoses? A critical aspect to understand in lumbar directional preference examination is this concept of peripheralization and centralization. Centralization is essentially where the patient has some form of distal symptom from the lumbar spine. So way over here, as a patient's got symptoms going all the way down their leg and foot. So as they perform a particular movement or position, symptoms start to leave the leg and felt just more proximally. Ideally, the symptoms would just be felt centrally, right in the center of the back. When that happens, it's common that the central pain might actually even increase. And that can be concerning to the patient if like, oh, my back's hurting more. But if the distal symptoms have abolished, that is a favorable response and critical to educate your patient to not be concerned about that. Now, the opposite is peripheralization. Peripheralization, they might even have a decrease in low back pain or just no effect, it doesn't change, but they are increasing the distal symptom. And that could be anything from pain or, numbness and tingling, whatever it is. That could be, it's just an increase of those distal symptoms. So peripheralization, that's going to be if it produced or increased distal symptoms, and it's no worse when you're done, well, that would be your yellow light. But certainly that's a red light if it remains aggravated after the test is over. That peripheralization is a red light. Centralization is one of the most profound findings that you can have in somebody with distal symptoms. There are so many studies that show if a patient exhibits centralization, their prognosis is excellent. This goes back to why the directional preference exam is the foundation of your lumbar examination. because it is going to be so effective when you find it.